talking about the high-yield signaling pathways for some of these endocrine hormones. They do like to ask about these, so I'll be going through these and telling you some easy ways to remember this. So starting with the intracellular receptors, these I'd say are pretty commonly asked. So some of these I think most of us will know. So like cortisol, testosterone, estrogen, progesterone, most of us will know that those are going to be intracellular because they're very non-polar hormones. So they'll tend to diffuse through the membrane, as you can see here, bind to receptor, travel to the nucleus, and then act as a transcription factor to increase the transcription of certain genes. But there's some here that are a little less known. So aldosterone, I think many of us would know. I'd say the thyroid hormone is one of the ones that I think a lot of people forget, including myself. And then vitamin D, those are some of the, I guess, less common ones. But easy mnemonic would just be pet cat. And then I guess vitamin D, just kind of remember that as a side point as well. And then for these, for like IP3 and CAMP, these I found ways to simplify it. So for example, IP3 here, you can sort of think of as GQ GOAT, so GnRH, gastrin, oxytocin, angiotensin 2, and TRH. You can notice I intentionally left out ADH and histamine, and that's because these are included in a separate page. If you go to the different receptor types and whether they're G, Q, G, I, GS, you'll see them there, and you'll notice that for both histamine and vasopressin receptors, they're both QS, meaning one is going to be Q and then two is going to be S, and that's exactly what you see over here. Is that you see V1 is going to be Q, so that's going to be IP3. V2 is going to be S, which is CMP, and you see the exact same thing for histamine. So you don't really need to include that into a memorization. You should just remember the receptors, and then you'll know how these function. So I would remember these primarily, especially oxytocin. That's a really weird one. Gastrin, also weird. Most people don't realize, like, oh, that's GQ, which is confusing. TRH as well, GnRH. Okay. Then you've got your CMP or GS pathways. Also, quite a big list here, but I found ways to sort of remember them in groups. So one thing you can think about is there's PTH and calcitonin. Both of them affect calcium levels, right? PTH is going to increase calcium levels in the blood, and calcitonin is going to reduce calcium levels in the blood, right? Calcitonin, it tones down the calcium levels, so you're going to have decreased calcium in the blood from calcitonin, but both of them affect calcium, so you can remember that they both act through CAMP pathways because it kind of looks like calcium. Then you've got ACTH and MSH. You should remember those together because ACTH is actually formed by, well, both of them are formed by the same sort of initial substance, which is going to be like pro-melanocytic, hormone, something like that. Sorry, I can't give you the full name, but it's one hormone that kind of breaks down into some of these, into both of these really. So that's just something to be aware of as well. And that's why if you have a really high ACTH signaling, you can oftentimes get a hyperpigmentation due to melanocyte-stimulating hormone, increasing melanocytes, and therefore getting some pigments. Now, just another thing you can group FSH and LH, both of them are stimulated by gonadal releasing hormone here, which you'll notice it goes Q here is gonadal releasing hormone, but then FSH and LH are going to be CAMP. And then you got TSH, CRH, HCG, GHRH, so growth hormone releasing hormone, and then those are, unfortunately, I don't have a great way to remember them, but those four as well increase CAMP. So I would, and then I guess glucagon also on this list, and the trick I have to remember that is that glucagon can actually be used as a treatment for beta blocker overdose. So if you go and learn the receptors, you'll remember that alpha receptors are going to be Q. Well, alpha 1's Q, alpha 2 is I, and then all the beta receptors are GS. So beta blockers would block GS, which normally increase CMP. So if you have too many beta blockers, you have a lot of blocking of this pathway, and so you can give glucagon actually to increase this activity of this pathway of CMP, and therefore you can treat an overdose on beta blockers with glucagon. So if you remember this one little factoid, it can help you remember not only that beta receptors are GS, and therefore increase CMP, but you can also remember that glucagon is also GS, and therefore if you block with beta blockers, you block the beta receptors, which normally increase CMP, you can counteract that with glucagon. And then CGMP, you can remember that, and this is going to be the mechanism of action of some certain drugs. So for example, sildenafil, so that's going to be for erectile dysfunction, and that's going to lead to an erection, and that's again going to be through inhibiting the enzyme that normally breaks down CGMP. So you have an increase in CGMP, which will lead to vasodilation and diuresis. So you got your BNP and AMP. That's both going to be natriuretic peptides. You got the brain one and you got the atrial one, but both of them are going to be natriuretic peptides that are going to increase urination or diuresis. And then EDRF, more commonly known as NO, is going to lead to vasodilation. So this is a smaller group, so this one I would say is going to be easy to remember after you've seen it a few times, but the other one's going to be a bit trickier. Now going down here to the RTK versus non-RTK. you want to remember for RTK, it's going to be MAPK is going to be the pathway. They can ask that sometimes, especially when it comes to insulin. They like to ask, like, oh, what will you see? And most likely it's going to be a bunch of things being phosphorylated, and they want you to just know this MAPK. And then growth factors as well. So I just accept TGF beta because if you go to the growth factor page in the pathology section of first aid, you'll see there's a bunch of growth factors there, pretty much all of these, as well as TGF beta. So I just accept TGF beta, but ultimately, in terms of the ones you need to know the signaling pathway for, just know all growth factors, right? If they give you a growth factor and they ask you, what's the pathway? It's always going to be RTK, which is going to be MAPK, and that's going to be pretty much the answer. Same thing with insulin. Now for non-receptor tyrosine kinase, it's a bit more involved, but still relatively simple. So you want to think JAK-STAT, and then you want to be thinking about NRTK is going to be JAK-STAT, and then I just wrote get NRP, meaning to say GCSF, EPO, TPO. Right? GCSF is going to be basically a precursor that's going to stimulate neutrophil production. Erythropoietin, that's going to stimulate red blood cell production. Thrombopoietin is going to stimulate platelet production. Right? So if they ask about the mechanism of, let's say, somebody who, they lost a lot of blood and now their EPO is high to try to increase that amount of red blood cells, and they're asking how does that work? It's going to be through JAK-STAT. It's going to be through non-receptor tyrosine kinase, right? And then they can also ask about prolactin. This is also kind of a weird factoid, so I'll remember that for sure. Just know, because prolactin is just kind of a rare thing, so people can easily get confused on that, so I like to ask about it. Just know that prolactin as well is going to be involved there. And you can just remember the last three here with pig. And just remember, okay, prolactin, all those ILs, IL this, IL that, interferons, all of these immunomodulators, all going to be non-receptor tyrosine kinase. And then growth hormone as well is going to be a non-receptor tyrosine kinase.